In this video, we're going to look at some of the other physiological concepts in ventilation and respiration. So in the last video, we talked about how in order to get airflow into and out of your lungs, you have to have changes in volume of your thoracic cage. And we said the relationship to volume and pressure was Boyle's law. So if y'all remember, we said that increasing volume of your thoracic cage decreased the pressure. And if your intrapulmonary pressure is lower than atmospheric pressure, then air is going to flow from high to low, which is into your lungs, right? That's inhalation. And then if you decrease the volume in your thoracic cage, you increase intrapulmonary pressure. And so if your intrapulmonary pressure ends up being higher, then you end up exhaling because the air goes from high to low, which is out of your body, right? So then air moves from inside your lungs to the air outside of you, okay? So that's just normal ventilation. We talked about that earlier. Now, there are some different factors, though, that can affect ventilation. So it's more than just volume and pressure. We also have things like airway resistance, alveolar surface tension, and something called lung compliance. So when we think about airway resistance, resistance is just a hindrance to flow, right? So in terms of measuring flow, we have this pretty simple equation here. So we're saying that flow, capital F, is equal to delta P. Anytime you guys see this little letter delta here in anatomy and physiology or just science in general, this always means a change in, right? So delta P would be a change in pressure, okay? And then you divide that by the resistance. Remember, resistance is a hindrance to flow. So to get the most flow, what you'd want then is to have a change in pressure but very low resistance. Because if resistance is a small number, your flow ends up being a big number, right? If you're dividing by a small number. But you still have to have a change in pressure. So I'll give you guys an example of where you would get no flow. Let's say if your mouth's open and your chest isn't moving. Air is not flowing, right? Even though your mouth's open, you'd think, oh, why does air move? My mouth's open, right? Well, if air's not flowing because there's no change in pressure, if your thoracic cage isn't moving, right? So if your delta P, your change in pressure, is 0, what's your flow? 0. Doesn't matter what you divide it by. It's always going to be 0. Okay. So first of all, you have to have a change in pressure, right? That's the driving force initially. Then that's under the influence of airway resistance. So airway resistance is determined mostly by airway diameter. So I'll give you guys an example. Like if you look at the door in this room, there's that little doorway there. Let's say if there was like a fire alarm and we all had to exit the room. And let's say if we all try to leave together. Well, we obviously all can't fit through that doorway at the same time. So we're going to have to kind of line up and then walk through kind of more slowly, right? So you can say then that door is actually some resistance to our flow, like the flow of people out of the room. That doorway provides some resistance, okay? So that could be good or bad depending on how you look at it. So how would we get more flow, do you guys think, like in and out of this room? What could you do in terms of that doorway? Make it bigger, right? If that doorway was 3 times as wide, all of us in here could just walk right out, no problem. So let's think about that in terms of your airways of your lungs, right? What if your bronchi dilated, like they got wider? Would you have better or worse flow? More flow, right? Exactly. And the reason being is that bronchodilation decreases resistance because you have a larger airway diameter so that you can get better flow that way, right? Opposite to that, we have bronchoconstriction. So bronchoconstriction, which would be a decrease in the airway diameter, that increases resistance. So if you increase resistance, what happens to flow? Excuse me. So if you increase R, what happens to flow? It decreases flow. Exactly. Good. So, but you have to always have a change in pressure to get any flow from the get-go, right? So what was the major kind of driving force behind our change in pressure? Like, how do we ever get a change in pressure in our lungs? What do we have to change in order to get pressure in our lungs? The diaphragm, right? Like the respiratory diaphragm, and I think you said volume, right? So you have to change the volume to change your pressure, right? So what would decrease the pressure in your lungs? What kind of change in volume of your thoracic cage would decrease the pressure in your lungs? Increase the volume of thoracic cage, right? So if you expand your ribs, right, that's going to increase volume but decrease pressure, okay? But we're talking about a difference in pressure. So what's the difference in relationship to? So it's intrapulmonary and atmospheric. So that's what the delta P is representing here, you guys. So we're saying the difference between intrapulmonary and atmospheric pressure. That's what the change in pressure is. So you're always comparing those two. And that's why we normalize atmospheric pressure at 0. Okay? So if there's any deviation from 0, then you have a positive or a negative number. Okay, cool. All right, guys, so what we can say then, based on this little equation here, is that gas flow changes inversely with resistance. So if you increase resistance, you're going to decrease flow. And if you decrease resistance, you're going to increase flow. Okay? That's the general rule of thumb. And so keep this in mind even for blood flow. Like when we get to blood flow, blood pressure regulation chapter later, the same equations applied there for blood flow. So keep that in mind. Okay, guys, so if we look at changes in airway resistance across your airway, what this graph shows you guys is resistance, okay, on the y-axis, and on the x-axis, you know, we have airway generation. And so airway generation refers to the number of branches here. So if you guys remember, the first branch would be the primary bronchus. The second branch would be the secondary bronchus or lobar bronchus. The third branch is the tertiary or segmental bronchus, and then we'd stop naming them after that, right? Remember that in lab? So we didn't talk about what the fourth one's called or the fifth one or so on and so forth, right? But what we can see though, you guys, is that it continues to branch quite a bit. So you go 4, 5, 6, all the way to 15, and then by the time you get to about 16 or 17 branches of the airway, that's where you begin the respiratory zone, right? So the respiratory zone was where you have like your respiratory bronchioles, alveolar ducts, and alveoli. That's where gas exchange can occur. So everything's shown in kind of like a light blue here. That's the conducting zone, so there's no gas exchange there. Everything shown in dark blue are the stages of branching where gas exchange can occur because they're small enough, right? And you can see there's a lot of branches here. I mean, even our models only show 3 of those branches, right? Just the primary, secondary, tertiary. But it goes up to 23 times until you get to the alveoli, which is kind of amazing. So that's why we call it a bronchial tree, because there's a lot of branches in your lungs. Now you can imagine then that along the way, resistance is going to change because, for one, every branch is increasing the surface area of, you know, the airway, right? So if you branch out, then you're actually increasing that surface area of the airway, okay? So what we find here, though, guys, is initially resistance of the airway increases up until your medium-sized bronchi. In fact, the medium-sized bronchi have the highest resistance. So if you really wanted to affect airflow, what this means then is that you'd want to regulate the diameter of medium-sized bronchi, right? Because if they have the most resistance, they kind of have the biggest influence on whether or not air is going to flow beyond that point, right? So what happens, you guys, is that your medium-sized bronchi, there's actually a lot of smooth muscle in those airways, right? And so they're under the control of your sympathetic and parasympathetic nervous systems, right? Sympathetic was fight or flight, parasympathetic was rest and digest. So what do you guys think you'd want to do to your airway diameter if you were like in a fight or flight response? Would you want it to widen or dilate or constrict or narrow? Widen, right? Because if you're in fight or flight and you need to have more airflow, that way you can kind of, you know, keep your oxygen levels up to keep your metabolism up in order to fight and or flight, right? You want to have good airflow, right? So what you can do then is your sympathetic nervous system then can relax the smooth muscle in these medium-sized bronchi, and this resistance can actually lower. So I know this kind of looks like a static chart, you guys, but the resistance along this airway can change. And it can change based off of airway diameter. There's lots of things that can affect airway diameter. You know, physiologically and normally it just would be like your nervous system finely tuning the muscles of your airways, right? But there's also other pulmonary disorders that can affect airway diameter too, like asthma, bronchitis, you know, obstructive pulmonary disorders like COPD. So, you know, we'll come back to these later, like in pathophysiology, right? Different class. But kind of keep that in mind, you guys. Medium-sized bronchi have the highest resistance. But beyond that, do you guys notice that resistance just continually declines? So it goes down, 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 down. So resistance is falling the more and more branches we have. And that kind of makes sense because every time these branches branch out, so to speak, you're getting more surface area or more airways. So your total cross-sectional area is increasing with every single branch. And so if you think about that in terms of airway diameter, your resistance is actually decreasing because of all these branches, okay? Then you get to the terminal bronchioles. Then the terminal bronchioles lead into the respiratory bronchioles, right? Respiratory bronchioles branch into alveolar ducts and then alveoli. That's where most of our gas exchange occurs. So remember, the respiratory zone is where a lot of the gases move across the respiratory membrane, right? How's our resistance at the respiratory zone? Is it high or low? Super low. So what does that tell us about flow at the level of our respiratory zone? Is our flow in the respiratory zone good or bad if the resistance is low? Yeah, it's good, exactly, right? Because if your resistance is low, then your flow is going to be really high. And that actually makes a lot of sense, because if that's where the gas exchange occurs, you want to have a lot of airflow to kind of replenish that air. That way you can get new oxygen into those airways to be absorbable. Does that make sense? Okay, cool. All right, guys, so with this example here, we're talking about, as you say, a homeostatic imbalance. Let's just use this for the sake of like asthma or something, right? So let's say if someone's having an asthma attack, what's going on there is they're getting bronchospasms, right? So bronchospasm is where the smooth muscle of your airway starts to contract, right? So it starts to contract and your airways narrow. Now, if your airways start to narrow, what happens to the resistance of that airway? It increases, right? So if you're having an asthma attack, what happens to airflow in your lungs if resistance is increasing? It decreases, right? And actually, this is one of the reasons why asthma can be life-threatening. You can actually have respiratory failure from a really severe asthma attack, because you might get so much bronchoconstriction that you don't have adequate airflow to support your body's metabolism. Okay? So you think, well, what do you do for someone who's had asthma or has asthma, right? Or is having an asthma attack rather? Well, what you can do is actually administer epinephrine, right? Epinephrine is a sympathetic hormone. So by administering epinephrine, you're effectively simulating a sympathetic response, right? And so what does your sympathetic nervous system do to your airway diameter? You guys remember? Does it cause it to constrict or dilate? Dilate, right? So it causes it to widen. So if your sympathetic nervous system causes it to dilate, it would make sense to give someone a sympathetic hormone like epinephrine. Now, I think on this example, they're saying, epinephrine dilates the bronchioles, activating these beta-2 receptors. You get smooth muscle relaxation, dilation of the bronchi. It reduces airway resistance. And we can add another arrow here, guys. What would we say? If you reduce airway resistance, what are you increasing? Airflow. Good. And that's kind of reversing this homeostatic imbalance. Awesome. Good job, you guys. Okay. So the other thing that affects proper ventilation, you guys, was surfactant. So we already talked about resistance. Now we're talking about surfactant here. If you guys remember, pulmonary surfactant was made by the type 2 cells of your alveoli. And remember, the function of pulmonary surfactant was to disrupt the surface tension in water molecules inside your alveoli. Do y'all remember going back to the last time we met, where what would happen if your alveoli had a lot of water surface tension in there? They'd collapse, right? They'd get sticky. So you want to break that surface tension. That way your alveoli don't collapse. So to keep your alveoli open, you have to actually impede or sort of interfere with the surface tension of the water that's in those alveoli. And that's what surfactant does. So pulmonary surfactant reduces the surface tension in alveoli, thereby preventing your alveoli from collapsing. Imagine this circumstance, guys. What if you didn't make enough pulmonary surfactant? And so that inside your airways of your lungs, what if your alveoli were collapsed? And you go to take a breath in. So you go to breathe. You're basically having to fight against all those sticky alveoli, which means every breath you have to breathe even stronger just to kind of try to pop those alveoli open, right? And so, in fact, sometimes you can hear this. So if you have this form of respiratory distress, sometimes you can hear those airways kind of snapping open and closed, and it sounds like little crackles in the lungs. They call it rales. You can hear like, I've had this before, and it sounds like pop rocks. But there's no pop rocks in your mouth, and the noise is actually coming from deep in your lungs. And so it kind of echoes up, and it comes out of your mouth, and it sounds like there's pop rocks in there, but there's not, which is the weirdest feeling. Like, oh, man, it sounds like pop rocks, but there's not in there. I don't have any in there. That's because your airways are kind of snapping open and closed. But if you make enough surfactant, you should be able to keep your alveoli open, which means you get good airflow. If your pulmonary surfactant levels are low, your alveoli could be collapsed, and therefore you're going to get poor airflow. So where do you see this? Like, under what conditions might you have less pulmonary surfactant? Well, one example here is infant respiratory distress syndrome. So with infant respiratory distress syndrome, or IRDS, you see this typically in newborn, premature births, right? So they're born earlier than they should have developed at birth. And so what we find, you guys, is that with premature births, their lungs aren't fully developed yet, and their pulmonary surfactant isn't really being produced in large enough quantities yet either, right? So we find, you guys, with premature births, sometimes they don't make enough surfactant to keep their airways open. So these poor little babies, when they're born, they're having to fight against the internal stickiness of their lungs. And you can identify this even just visually, looking at them. You're going to see that they're really struggling to breathe. Because imagine this, you guys. You got to take a deep breath in. We all can just take a deep breath in, and it's easy, right? Just flows right in. But imagine if your lungs were internally sticky because there's no surfactant and your alveoli are kind of collapsed. When you go to take a deep breath in, there's some resistance there because you're basically fighting the kind of stickiness of your lungs. So what it's going to look like are a lot of really kind of powerful respirations, right? So you start to expand your thoracic cage, and they call this retractions, where you kind of see the thoracic cage also elevate. So it's going to kind of look like, right? And they're using a lot of neck muscles and accessory muscles of ventilation to try to contract, so that you're going to see sternocleidomastoids involved, scalenes involved, even pectoralis. So you're going to notice that it's labored breathing, right? So what can we do for these individuals? Well, there's certain hormones you can administer that can stimulate pulmonary surfactant. You can also do pulmonary surfactant lavage, where you literally just wash their lungs with a solution that contains surfactant, right? So it's kind of interesting. All right, guys, so the third one here is lung compliance. And so if you think about the name, like to be compliant, right? To comply with something means you kind of follow along with it, right? So lung compliance refers to the ease of stretchability of your lungs, okay? Because if y'all remember, your lungs are adhered to the thoracic wall. So when you go to expand your thoracic cage, they're also pulling on the lungs because the pleura anchor those two together. So you have your thoracic cage, you have your lungs, and they're anchored by pleura. If you have good compliance, what's going to happen then is when you expand your thoracic cage, the lungs will follow because they're just kind of following and they're complying with what the thoracic cage is doing, right? So if the thoracic cage is expanding and the pleura are pulling on the lungs should be expanding with it, right? So what if you had poor pulmonary compliance and you go to expand your thoracic cage, right? Thoracic cage is expanding, the pleura is pulling on the lungs, but what are the lungs doing though if they're not compliant? They're not going with it, right? They're not expanding with the thoracic cage as easily, maybe a little bit, but not as easily as they should, right? So what you're finding is that the lungs aren't just kind of like easily going with the thoracic cage. They're kind of more internally rigid, and that way they're more difficult to follow along. They're less compliant. If they're not able to expand as well, then you're not going to get good airflow because you're not going to get that drop in pressure that you should see when you increase your thoracic volume, right? Because we made an assumption back before. We said if you increase thoracic volume, your intrapulmonary pressure should decrease. But that's only true if the lungs expand with the thoracic cage. That way the volume of your lungs is also increasing, right? But there are certain conditions where your lung compliance is actually lower, where your thoracic cage can expand, but your lungs don't expand with it, right? Which means you don't get that big drop in intrapulmonary pressure, which means without that delta P, you're not going to get good airflow. So conditions that lower lung compliance also decrease ventilation, and you get really poor airflow in that regard. So you might wonder, well, what's lung compliance due to, right? Like how could your lungs be more internally rigid? Well, it's usually due to an accumulation of non-elastic scar tissue in the lungs, right? So if you've had like chronic bronchitis or chronic asthma or chronic infection, just some sort of like chronic irritation of the lungs, this is also why they're worried about, I'll give you an example, like asbestos, right? Or you guys heard of silicosis, where if you're like inhaling a lot of dust, that dust can also irritate your lungs. Or you guys heard of anthracosis or coal miner's lung? They call it black lung or whatever, because a lot of carbonaceous deposits build up in your lungs. Well, that all leads to inflammation, which can lead to scar tissue, and that scar tissue is kind of rigid, and so it actually prevents your lungs from properly expanding. Okay, so that kind of makes sense. Like normally your lungs should be about the consistency of like a Tempur-Pedic mattress, kind of spongy but have some recoil there, and they're going to have some give to them. With basically a lot of this non-elastic scar tissue, they don't have that characteristic anymore. They're going to be more tough, which as far as your lungs are concerned, that's not a good thing because you want your lungs to be able to expand with them, right? But what also decreases lung compliance, you guys, is a lack of surfactant. And that kind of makes sense too. Because if your surfactant levels are low and your lungs are internally sticky, they're not going to be as compliant because when your thoracic cage goes to pull on the pleura and the pleura pull on your lungs, well, if the lungs are kind of sticking together from the inside, they're not going to want to expand as well, right? So that's also going to limit your lung compliance. Okay, cool. So it's diminished by non-elastic scar tissue, less surfactant, even decreased flexibility of the thoracic cage. So what do you guys think could maybe affect that? What are some things that might decrease the flexibility or stretchability of your ribs and your thoracic cage? What do y'all think? Yeah, broken ribs, good. So if you break a rib, let's say that even while the rib is broken, if it's really painful, you're not going to want to breathe, right? Because it might even be so painful that it overrides your drive to ventilate. Because every time you take a deep breath in, it's like, it hurts too much, right? So that's going to decrease lung compliance, good. But what about when that rib heals? Imagine a circumstance when the bone reheals, that area of new bone might not be as bendable as the rib normally is, right? So that area of kind of like newly formed bone that's not remodeled yet, that could be also somewhat non-elastic or not really bendable as the normal healthy bone that's well formed, right? What else, you guys? Like your ribs are only part of the thoracic cage, right? What's this part made of? What's the anterior part made of? Cartilage, right? It's hyaline cartilage. So what if your hyaline cartilage also became more rigid? In fact, there's certain conditions where your hyaline cartilage from repeated trauma can actually get more mineralized and more calcified. So what if your hyaline cartilage became more like mineralized and hardened? Well, that's also going to prevent you from expanding your thoracic cage. So it kind of makes sense. There's a bunch of conditions of the thoracic cage, you guys. And so we'll go back into these in pathophysiology, but kind of keep that in mind, though. That also affects lung compliance because in order for the lungs to be compliant, the thing they're compliant with is your thoracic cage. So ultimately, it boils down to what's the thoracic cage doing. If the thoracic cage can't expand, then your lungs aren't going to expand with it, right? Cool. All right, guys, so just to summarize the three factors that affect ventilation, what were those three? What was the first one we talked about? Airway resistance was the first one. What was the second one? Surfactant, and then the third one was compliance. Good. So airway resistance, surfactant, and lung compliance. So don't forget those ones, guys. Those three are really important. Okay, so we actually went over these types of values back in lab, but let's review and summarize these again together. So what we're looking at here with this picture is spirometric data, right? So what a spirometer does is it measures airflow or ventilation over time. So what we see here, you guys, are milliliters of air over time. And so what you're seeing here with these little tiny humps, this is called tidal volume. And so this would be like a inhalation, exhalation. And so during tidal volume, what you're looking at here is just a normal, quiet breath. Like if you're at rest and you're not breathing heavily, you're not thinking about breathing, but you are breathing, right? Just sort of normally and quietly. That's tidal volume, which is right around 500 milliliters or half of a liter, right? So, but if you look at the peak of tidal volume, let's say if you go to take a small breath in, and then you keep going, you go to the maximal amount of air you can take into your lungs. That would be the peak. There would be inspiratory reserve volume, or IRV. Okay, so your inspiratory reserve volume is the maximal amount of air that you're able to inhale right after the peak of tidal volume inhalation. Okay, so this ends up being about 3,100 milliliters or so. Okay, but then let's say from the peak of your maximal inhalation, let's say if you go to exhale all the way down, right? So you actually already at your peak up here, so you've already inhaled, and then you go to exhale all the way down, right? All the way to the very bottom. You can't get any more air out anymore. Right down there, you guys. The very bottom here, that's your expiratory reserve volume, okay? And so the total expiratory reserve volume is actually the difference between the base of tidal volume and this down here, which is 1.2 liters. But if you add up inspiratory reserve volume, tidal volume, and expiratory reserve volume all together, you get something called vital capacity. So vital capacity is the total amount of air you're able to inhale and exhale at your maximal amounts, right? So they're saying the average vital capacity is right around 5 liters or so, okay? But do you guys notice that if this is the deepest exhalation, what you find though is there's still some air in your lungs because this is not on 0, right? So you guys see that this residual volume here is the air that's left in your lungs after you've fully exhaled. So that residual volume ends up being about 1.2 liters. And you might wonder, why the heck is there any air left in your lungs after you exhale? Well, in order to get all of that air out, you would have to collapse your entire lung, right? So because your lungs don't collapse fully every time you go to exhale, you actually don't exhale all that air out. But here's the problem with this, you guys, is that residual volume, I mean, it's good because it keeps your lungs inflated, but it also is, you can think of it like stale air, right? Residual volume will be the air that's left in your lungs from like previous breaths. So your residual volume could potentially be high in carbon dioxide and low in oxygen. So that means that when you go to inhale, right, what you inhale has to mix with this residual volume along the way. So already immediately, the air that you inhale is lower in oxygen and higher in carbon dioxide, okay, already. So that's because it's mixing with this kind of stale air, you might say. So the reason why we care about these respiratory volumes and capacities is that clinically, you can measure these to help to determine someone's respiratory status, right? Like you can understand if they have an obstructive or a restrictive pulmonary disorder, or you can understand if their ventilation is normal, right? And so you can actually measure this clinically. The ones we used in lab were not as precise and definitely not the ones you would use like in a clinical setting, but they're good just educationally, right? You get some nice, decent numbers. We had to be kind of tricky with it because our spirometers only measured exhalation, right, not inhalation. That's why we had to like take things like our vital capacity and then, you know, our tidal volume as well as our expiratory reserve volume to figure out and do the math for inspiratory reserve volume. Because we actually couldn't measure inspiratory reserve volume directly. We had to kind of just shuffle some numbers around from what we could measure and do a little bit of algebra, okay? So cool, you guys. Do y'all have any questions on these data? So let me ask you guys this, though. What do y'all think would happen if you had poor pulmonary compliance? What do you guys think would happen to your vital capacity if your pulmonary compliance was low? Do y'all think that might change? You would think it would, right? And honestly, it just depends on the degree of compliance, okay? So what you'd find is if there's just a slight change in compliance, you could potentially have the same vital capacity, but it could just take you longer to inhale and exhale because the lungs are just moving more slowly, right? But let's say if you had like infant respiratory distress syndrome where alveoli are collapsed and they're so sticky that when you go to inhale, they don't even open up, right? And so if you're actually having collapsed airways, then you are going to change your vital capacity because you're actually changing the amount of potential volume that could even enter your lungs from the get-go, right? So that actually makes a lot of sense. So when you think of total lung capacity, guys, all it is your vital capacity plus residual volume, okay? Now what's kind of weird, though, is in disorders like emphysema, your total lung capacity increases. And it increases because emphysema actually increases pulmonary compliance. But the problem here, though, is that with emphysema, you get a decrease in vital capacity and an increase in residual volume. So what happens is they get a lot of trapped air in their lungs. How could that be a bad thing for your body if you increase residual volume and you have even more trapped air in your lungs? What do we think about residual volume as being? It's like stale air, right? It's the air that was already in your lungs and you can't exhale it all. So when you go to take another breath in, it has to mix with that residual volume. So if your residual volume is greater, that means you're having to mix each breath with even more of that stale air, you might say, right? And what that means is your oxygen levels are going to be even lower and your carbon dioxide levels are going to be even higher. So what this means is they're really going to have to struggle to breathe to get a sufficient amount of air into their lungs to mix with all that residual volume just to get enough oxygen in to even absorb that into your bloodstream. So what you're going to find then is like emphysema, usually their PO2 level is going to be lower than like the average person, right? Unless they're on oxygen or something. Okay, guys. So what's this thing called dead space? Well, dead space, there's two major types. We have anatomical and alveolar dead space. Anatomical dead space is where it's air remaining in the passageways that doesn't contribute to ventilation, okay? So think about this. You gotta take a breath in, a lot of that air is going to make it down into the respiratory zone, right? But some of that air never actually made it into the respiratory zone. It stayed in the conducting zone, right? Like you take a deep breath in, there's still some air trapped in your trachea, right? There's still some air trapped in your larger bronchi. That's what we call anatomical dead space, and it's air that never contributed to gas exchange because it never made it to the respiratory regions. So this ends up being about 150 milliliters or so. So it's not a whole lot. And then we also have alveolar dead space. So alveolar dead space is basically due to collapsed or non-functional alveoli. So this would be the volume of air that you find in alveoli that don't participate in gas exchange. And this could be because they have a mucus plug, or because maybe they don't have good blood flow from damage of blood vessels, or maybe there's actually like a blockage of the blood vessel that's serving those particular alveoli. So that would contribute to what we call alveolar dead space. So the total dead space is just the sum of both of those. And so you might wonder, well, why would you want to know how much dead space you have inside your lungs? Well, if you know how much dead space is there, then you know how much air isn't contributing to gas exchange. So then, let's think about this, you guys. When you go to take a breath in, did all the air you inhale participate in gas exchange? No, right? In fact, which of that air didn't contribute to gas exchange? Dead space, right? So how could it be important to know how much dead space someone has? Think about this like clinically. What if someone has a lot of dead space and they have a very fast ventilation rate? They're going. If you just looked at them, you go, yeah, they're breathing pretty well, right? They should be getting enough oxygen. But what if they have a lot of dead space? Just because they're ventilating doesn't mean that they're actually respirating, right? Respiration is gas exchange. So what if someone has a lot of dead space, but their ventilation rate is high? Yeah, they actually might not even be getting enough oxygen that way, which is kind of interesting. So we actually have an equation for this, and it's called alveolar ventilation rate, or AVR. So to calculate your alveolar ventilation rate, and basically what this tells us, by the way, is how much air is reaching the alveoli to participate in gas exchange, right? And so the way we calculate this, guys, is frequency of breaths per minute. By the way, do you guys know how many breaths per minute is normal at rest? Yeah, between 12 and 20 or so. Good. So if it's faster than that, then you're talking about hyperventilation. If it's slower than that, it's hypoventilation. And those could be physiologically relevant. We'll talk about that later with blood pH regulation. But frequency of breath per minute, maybe about 12 or so per minute, right? The lower end of normal, let's say that. And then what we would multiply that then is the volume of air you take in minus dead space, right? So you take your tidal volume and subtract that from your dead space. And what that gives you then is a more accurate value about how much of that air that you inhaled actually participated in gas exchange, right? So what alveolar ventilation rate tells us is the amount of air that you inhaled that reached your alveoli and was able to participate in gas exchange in 1 minute, right? And so this is important to note clinically, because if someone has a lot of dead space, even if they're ventilating really rapidly, their alveolar ventilation rate could actually be low. Let's think about this, you guys. Let's say if someone's breathing heavily, like they're hyperventilating, right? Their frequency is high, but just because you have a high frequency doesn't mean your alveolar ventilation rate's high, because think about this. You have to consider how much dead space they have. So what if their tidal volume was normal, but their dead space was like astronomically high? This could actually even be somewhat close to zero under certain conditions, like with a pulmonary embolism, you're not getting a whole lot of blood flow to those alveoli, and they're not getting good gas exchange there because they're non-functional alveoli. Your alveolar ventilation rate could actually be fairly low, even if your ventilation is high, right? If your airflow is high. But if you're not getting good air and gas exchange in your alveoli because your dead space is high, then your total amount of AVR is low, which is kind of interesting, right? So you might see this in certain conditions. Like, you guys heard of like deep vein thrombosis and stuff? So DVT, where like someone has a blood clot that dislodges and then goes up to their heart, and their heart pumps it in their lungs, and that blocks the pulmonary artery. That means that you might even have an entire lung that's not getting good blood flow. So what that means then is that entire lung it has non-functional alveoli because they're not having good gas exchange because there's no blood flowing through them, right? So that with that kind of condition, someone can still ventilate. They might have a blocked blood vessel in their lungs, but they're still trying to breathe, right? But just because they're taking air in doesn't mean that that's actually participating in gas exchange. So that's just why we want to consider this, clinically. So that kind of makes sense. All right, guys, cool. So what we're going to do is next move on and talk about internal versus external respiration. So if y'all remember, ventilation was airflow, respiration was gas exchange, and there's a big difference there, right? So remember, the conducting paths of your upper and lower respiratory tracts, those ones just are involved with ventilation or airflow. Respiration is gas exchange, right? So do you guys remember where respiration occurs? Where does gas exchange occur in the lungs? Alveoli, alveolar ducts, and respiratory bronchioles. Okay, those are all part of the respiratory zone where gas exchange can occur. But you're right, it's mostly alveoli. Good. Okay, so if gas exchange is occurring between air and blood, we call that external respiration because you're moving gases between the external air and your own bloodstream, right? So it's external respiration. If gas exchange is occurring between your blood and your tissues, we call that internal respiration because you're moving gases between your own tissues and your own bloodstream internally in your body, which means it's internal respiration. And you got to have both, right? Because that's the whole point of this process, right? You're trying to absorb oxygen from your atmosphere. Your blood's going to deliver that oxygen to the tissues via internal respiration because the oxygen is going to leave your blood and into the tissue, right? And so you need to have both internal and external respiration for adequate homeostasis. Now, both involve physical properties of gases and the composition of gas, right? Now, here's the thing about gas movement, you guys, across these membranes, is these gases only move via diffusion, okay? That's their main driving force, is diffusion. So, diffusion is a process where you go from high concentration to low concentration. So if you're seeing the gases move anywhere, it's because of diffusion gradients, right? So keep that in mind, right? When we go to the next slide, I'm going to ask you guys, where's the concentration higher? You got to look at the arrows, right? So if the arrow is going in one direction, and maybe this way, you got to assume that the concentration is higher here and lower here because that's the direction of flow via diffusion, from high to low. Okay, now it also depends on the solubility of that gas as well. Solubility refers to the dissolvability of the gas, right? So because these gases have to dissolve within the watery environment of your body, if the gases are less soluble, they're not going to flow as easily, right? If they're highly soluble, like carbon dioxide, they're going to move much more easily because they can just come right in. They can dissolve in really easily, okay? So now when we talk about gas composition inside of your bloodstream and even the atmosphere, we actually refer to it by its partial pressure. So remember going back to the first lecture in this chapter, we talked about atmospheric pressure. Remember at sea level, atmospheric pressure was 760 millimeters of mercury. It turns out at Denver, because we're a mile high, our atmospheric pressure is only 680 or so millimeters of mercury. At sea level, it's 760. So it's a lot greater at sea level because they have more column of air above them. So there's a higher pressure, which makes sense. Okay. So the thing though about our atmosphere is that it's made of more than just oxygen and carbon dioxide. You also find nitrogen. In fact, nitrogen is the most abundant gas in air. In fact, you can feel air, right? Like if you move your hand around, you can feel the gas in this room, which is kind of interesting, right? You can feel that it's there and it exists because there's some resistance to its movement if you kind of wave your hands around, okay? Now, each gas in the atmosphere and even in your body exerts its own partial pressure, right? Think of partial pressure as being like each individual gas's component of the total sum, which would be 760, right? So there's a certain amount of that 760 millimeters of mercury of atmospheric pressure that's just due to nitrogen, right? So nitrogen contributes to most of that 760. Then it's going to be oxygen's component because oxygen is about 20% of our atmosphere, right? So oxygen will contribute to about 20% or so of that 760. Then it's going to be carbon dioxide and water vapor following that. Okay. So when you think about partial pressure, you guys, we kind of think about this as concentration. And if you're taking a general chemistry class, isn't the case. So don't transfer this into a chemistry class that partial pressure is the same as concentration. That's not always true. But as far as what we're considered here in this class, just think about partial pressure as being the concentration of that gas, right? So what if you have a partial pressure of oxygen that's 100 here and a partial pressure of oxygen that's 40 here? Where's the oxygen going to flow? This way, right? Down to the area of lower pressure, which is 40, okay? And so that's like your concentration gradient, or the pressure gradient, rather, okay? But don't get too hung up on the partial pressure thing, you guys. Just think about this as concentration. And the way it's denoted is P. So you're going to see PO2, PCO2, right? And so that represents the partial pressure. But just think of that P as meaning concentration. It's not really, in terms of chemistry, but as far as we're concerned here, it's good enough, okay? So when we look at the composition of gases in our atmosphere, you guys, it's actually mostly nitrogen, which plays no important physiological role in our bodies, but it accounts for 78.6% of the atmosphere that we're surrounded by, okay? Now, because it's such a high percentage of our atmospheric gas, it also contributes to the most of the partial pressure of our atmospheric pressure, right? So 597 of the 760 is only due to nitrogen, followed by oxygen, which is about 21% or so, and that contributes to about 159 of that 760 millimeters of mercury of atmospheric pressure. And then then it's followed by water vapor, which is 0.46%, and that contributes to 3.7%. Now this can change though, right? Water vapor concentration can change in the atmosphere because of humidity. So humidity plays a role too. So this is like more of an average. This is not constant because your humidity of the atmosphere can increase, which means that water vapor could actually contribute a larger role to that partial pressure. Okay, and then CO2 contributes only about 0.04% of the atmospheric composition, and therefore only about 0.3 millimeters of mercury. Okay, so it's in fairly low concentration in the atmosphere. Now, when you look in your alveoli, these things change though. So what do you guys notice that's different between alveoli and atmosphere, between those two? The composition of gas changes. So what's different between those two? Yeah, H2O increased a lot, right? How would that make sense? Why would you have more water vapor inside your airways? What's that? Yeah, from moisture, right? And that's one of the functions of your airway was, remember, to humidify the air as it goes down. So you're actually seeing, very good, you're actually seeing the humidity here increase as the air descends deeper into your lungs, because all along the way is in fact a mucous membrane. So you're actually putting a little bit of water in that air before it reaches the alveoli. Okay, good. And then you also mentioned that CO2 increased, right? So it's kind of weird. We're saying that CO2 increased, and actually quite a bit. Isn't that amazing, you guys? We went from 0.04% to 5%. That's a lot. So it almost increased 100-fold. So you get a 100-fold increase in CO2. Okay. So what's going on there? Where'd that CO2 come from? Yeah, from inside your body. Very good. So it came from your bloodstream, but it was dumped out into alveolar gas. And then what's up with O2? Why did your O2 levels decrease in alveoli? Because you absorbed it. Very good, yeah. You absorb the oxygen from your alveoli into your bloodstream, and that's why your O2 levels decreased. Make sense, you guys? Cool. So, awesome. So what we're going to do here is look at basically how fast this process of respiration occurs, right? Remember, respiration is gas exchange. So what's the driving force behind respiration? Y'all remember? Concentration gradient, right? So partial pressure gradient. So you'd say if your PO2 levels are 100 here and they're 40 here, oxygen's going to move towards the 40, right? So let's check this out, you guys. On this side, we're saying, by the way, we're looking at blood, and it's blood that's flowing across the alveoli over time. So the blood that's coming to your alveoli via the pulmonary artery only has 40 millimeters of mercury. Now, that's about as low as it goes physiologically, and we would call that deoxygenated blood. That's not literally deoxygenated because there's actually, some oxygen there, right? In fact, there's 40 millimeters of mercury of oxygen there. So so deoxygenated blood is more of a misnomer. Like you're never going to get down to 0% oxygen in the blood. But when it's low at 40, we call that deoxygenated blood. In fact, that's why it's blue. You guys remember blue on the vessels means deoxygenated. However, this would be the deoxygenated blood that's coming to your lungs through the pulmonary artery. So this is one of those examples of blood that's in an artery that's actually deoxygenated. Okay. Now, as the blood flows through the capillaries that surround your alveoli, do you guys see that all of a sudden that blood becomes more and more oxygenated? It actually gets fully oxygenated up to about 104 millimeters of mercury in only 0.25 seconds. 0.25 seconds is 250 milliseconds. That's about like a average reaction time, give or take. You know, so think about like what your reaction time would be to like a stimulus. Like if I said, okay, everybody, stick your thumbs up that you understand this. Now, you go, thumbs up, right? It'd take you about 250 milliseconds to do that. But that's pretty fast, right? So what you're seeing here, guys, is the process of oxygenation occurs pretty much instantaneously as that blood flows across the alveoli, right? However, this is under the control and under the influence of a diffusion gradient. So to actually get gas exchange where blood can actually oxygenate up to about 100, you have to have a diffusion gradient, right? If that diffusion gradient's not there, like if your O2 levels are low inside your lungs, like close to 40, you're not going to get 100 millimeters of mercury, right? That's only dependent on the diffusion gradient based on your alveolar composition of gas. So the next key point here too, guys, is what's up with this plateau? Why don't you just keep oxygenating your blood forever? What do you guys think determines that plateau? Where like the oxygen levels kind of taper off and your blood doesn't continue to keep oxygenating. It's kind of some balance, like homeostasis. It's a good hypothesis. That ends up being about the homeostatic level, but it's not because your body made it that way. Yeah, that's a good thought though. What do you guys think? To absorb the oxygen, where's it going? When you absorb it, where's it being absorbed into? In your blood, right? So what do you guys think this means then? When you've reached this point where you can't absorb anymore, what would you call that? Saturation or capacity, right? So your blood, if you think of blood like a sponge, it can only soak up so much, and you're going to absorb enough to where it can, soak up, so to speak, and you can have an oxygen saturation. So if your oxygen saturates at 104 millimeters of mercury, that's pretty normal. That's a normal oxygen saturation. Okay. If it saturates lower than that, then you start thinking about things like anemia, which would be lower O2 levels in blood. And there's a lot of things that can cause that, right? That's why, because think of a blood, it can only hold so much oxygen. You've saturated that blood in the first 250 milliseconds that the blood moved across the alveoli, which is pretty phenomenal, right? It's fast, very fast, which makes sense because we need to get that oxygen in our bodies. Okay, so remember, gases move based on this partial pressure gradient. So in venous blood, that's going to, for the venous blood that's going back to your heart, it's going to be high in CO2. And for the alveolar blood that's just passed across your alveoli, that's going to be low in CO2 because you've actually delivered the CO2 back into air. But look at this, you guys. The difference is only 5 millimeters of mercury. What was the partial pressure difference between oxygenated blood and deoxygenated blood? What was oxygenated blood at? What was the number there? You have to go back to the last slide. What is it? 104. What about deoxygenated blood? 40. Good. That's a big difference, right? In fact, it's more than double. How about over here? The difference between CO2 in venous blood versus arterial blood in the periphery is only 5 millimeters of mercury. You're saying like less than 20% difference, which is kind of interesting. So there's a small difference in the concentration gradient of carbon dioxide, but carbon dioxide is 20 times more soluble in water, so it can diffuse really quickly. Okay, so that's what allows you to actually get rid of CO2 pretty rapidly. Even though there's a small concentration gradient or potential difference there, CO2 just still moves pretty fast because it's more soluble than oxygen. Okay, so looking at this slide here, you guys. By the way, we can't eat in lab. Thanks. So looking at this slide here, I know we're technically in lab now. So we have inspired air, right? So for the air that you take in via your lungs, O2 levels are really high, CO2 levels are really low, right? But by the time that air reaches the alveoli, your O2 levels drop down and your CO2 levels rise because you already start immediately absorbing oxygen and dumping off CO2 into your alveolar air, right? And so that's why we see a big increase in CO2 and a decrease in O2 in the gas in your alveoli. And that makes sense because O2 is going in, CO2 is going out. So what's the driving force behind the direction of these gases moving? If oxygen is going from here to here, what are we assuming about the concentration gradient? From high to low, right? But where must it be higher if oxygen's flowing into blood? Higher where? In the gas or in the blood? In the gas. Good. Nice. So it's higher in the alveolar gas, lower in the blood. That's why it's moving in the bloodstream. Nice. What about CO2, you guys? Where's the concentration of CO2 going to be higher? In the blood or in the gas? In the blood, right? Because that's why CO2 is going from blood to the gas, from high to low. Okay, cool. So for that oxygenated blood that's going back to your heart, we call this the pulmonary vein, by the way, because it's carrying blood back to the heart. Now these pulmonary veins are carrying oxygenated blood. And then the heart's going to pump that blood out to the rest of the body. Now this blood in your systemic arteries has higher O2 and fairly low CO2 because you delivered that out into the atmosphere. Now, by the time this blood reaches your tissues, we also see that the gases start moving again at the capillary beds of your tissues, right? So oxygen's moving from blood into tissues. So where must the oxygen concentrations be lower than if oxygen's going into the tissue? In the tissue. Good. So what keeps oxygen levels low in the tissues? I'll give you guys an example. Like if you're delivering oxygen to the tissues, why don't your oxygen levels just stay high and you stop delivering oxygen there? Yeah, you're using it. Exactly. Good. You're using that oxygen. And as you use it, that decreases the concentration of oxygen, right? Cool. How about CO2, you guys? Why are CO2 concentrations higher in the tissues? Or how are they higher, rather? Like, where'd that CO2 come from? So CO2 concentrations are higher in the tissues and lower in blood. But how are CO2 concentrations higher in the tissues? Say it again. It's being created, right? Good. So where is it being created, though, CO2? Not created in the blood, no. By the cells. So CO2 comes from cells from where? Think mitochondria. What's going on there? Yeah, good. Krebs cycle and your oxidative phosphorylation chain. So CO2 is derived from cellular metabolism. Now, when CO2 dissolves in water, it actually forms an acid called carbonic acid, and you have to get rid of this acid, otherwise your body tissues start to acidify. So if you have metabolism, let's say if your tissues are highly metabolically active, right? What are the oxygen levels in your tissues going to be if your tissues are highly metabolically active? Would they be high or low? No, if your tissues are highly metabolically active, would oxygen levels be high or low? They would be low because, why? They're using it, right? If they're undergoing a lot of metabolism, they're using that oxygen. Good. So we call it hypoxia. Good. If your tissues are highly metabolically active, would the CO2 levels be high or low in the tissues? High, because CO2 comes from metabolism. Good. Okay, keep that in mind. That's what keeps this gradient going. Okay. So, by the way, we call this internal respiration because gases are moving between blood and tissues. So CO2 moves into blood, and then for that venous blood that's going back to your heart, it's actually low in O2 and high in CO2. So it's low in O2 because your tissues used it, and they kind of absorbed that from the blood. And it's high in CO2 because CO2 is a waste that your tissues create, and the blood picked up that waste from the tissues, right? So then your heart pumps that blood back to the alveoli, and so for the pulmonary artery that carries this deoxygenated blood, by the way, is it really deoxygenated? No, right. So we talk about it as being around 40 millimeters of mercury. which is not fully deoxygenated, but we still call it that. And so then what happens next, you guys, is we actually can have CO2 leave the bloodstream, enter our alveoli, because CO2 is higher in the blood and lower in the atmosphere. And then oxygen gets absorbed into the bloodstream because oxygen is higher in the atmosphere and lower in the blood at that point. Okay? Have this down like the back of your hands and know where CO2 is coming from and where O2 is going for sure. You have to know this. Can't pass AMP2 without knowing that. For ventilation-perfusion coupling, this is a really interesting concept, you guys. So this idea is based on the fact that your heart doesn't pump as much blood as your lungs can hold, which means that at any moment in time, your lungs only get about 20% perfusion, right, during rest, which is kind of interesting. So that means that 80% of your 80% of your lungs at any moment in time are not fully perfused. That's because your heart doesn't pump out that much blood. Okay, let's think about it. I mean, it does pump out a lot, but not enough to fully perfuse each lung. So let's think about this, you guys. Is if you can only perfuse or send blood flow to 20% of the lungs, which 20% would you choose? Let's say if you had to pick 20%. Which 20% of the lungs would you choose to send blood flow to? Which would make the most sense? Alveoli, good. But let's say, remember, not all alveoli are created equally, and not all alveoli get the same amount of airflow. What's that? Oh, the medium-sized bronchi? No, not the medium-sized bronchi. Oh, that's a good guess. Maybe for resistance, right? You guys are close, though. Something with alveoli and something with airflow. But what would make the most sense, though? We know that not all alveoli get the same amount of airflow, right? So where would you want to send that blood to? You can only send blood to 20% of the lung at any moment. So which 20% gets the blood? Would you want to send it to Would you guys want to send it to alveoli that are plugged with mucus? Hell no, right? Where would you want to send it? What's that? Healthy alveoli, right? So how do we define a healthy alveolus then? What does that mean? I know you guys have to think in this class. Darn it. I mean, you can't just sit and listen and watch me like a TV. If that were the case, you would have to show up to class. You know what I mean? Just watch me at home. Ones with a surfactant, good. So because they have to have surfactant, what's their condition? Are they collapsed or open? Open. If they're open, what could they potentially be getting? Good airflow. Okay. So if not alveoli are created equally, some get more airflow than others. Which 20% would you want to send the blood to? You got it. The ones getting the best airflow. Does that make sense? Cool. So the ones getting the best airflow get the best blood flow. And so we call that ventilation-perfusion coupling. So if you have alveoli that get good ventilation, then you want to send perfusion to those alveoli. And the way this works is chemoreceptors. So for the alveoli that get poor airflow, their CO2 levels are going to be high, and their O2 levels are going to be low, and you're not going to want to send not going to want to send blood to those particular alveoli, right? Okay, so let's check this out, you guys. By the way, this little gold thing is supposed to show an alveolus. So what's the difference between this gold alveolus and this gold alveolus? Well, this one looks more plump, right? This one's a little more shriveled. And so the difference here, guys, is this one's trying to say there's not as much airflow, and this one is saying that there is more airflow, right? So if you have an alveolus that has poor airflow, do you want to send blood to that alveolus? No, it would make no sense, because why on earth would you send a finite resource like blood to something that's not going to do anything for you, like gas exchange, right? So what you do then is, if for poorly ventilated alveoli, if you vasoconstrict the pulmonary arterioles that lead in those alveoli, then you decrease the blood flow in those alveoli. That way you can match the two. Poor airflow is matched with bad blood flow, right? And that's why you want to keep those sort of at the same level, okay? That's the change there. but this is under the influence of CO2 and O2 levels. So it makes a lot of sense, though, that your CO2 levels would be high in an alveolus and your O2 levels would be low in an alveolus that gets poor airflow, right? Like imagine if this is plugged with mucus, and you're not able to replenish the oxygen in there, then your CO2 levels are going to be high, O2 levels are low. There's chemoreceptors in these blood vessels that can sense that. And when they pick up that information, they automatically vasoconstrict, which decreases blood flow to that alveolus. Let's look at the opposite of this, you guys. What if you have an alveolus that gets really good ventilation or airflow, right? What are your oxygen levels going to be in that alveolus? High or low? High, good. How about your CO2 levels in the alveolus? High or low? Low, good. And so the same chemoreceptors can sense that, and so what they can do then is dilate the blood vessels. So if you dilate the pulmonary arterioles, that decreases resistance, so you get more blood flow, and that way you can increase blood flow to this alveolus. That way good ventilation is matched with good perfusion. That's ventilation-perfusion coupling. How fast do you guys think this happens? Good to guess. It's not really, you don't have to be right necessarily, but how fast do you guys think this happens? What's that? Pretty much instantly. Yeah, exactly. It's pretty much instantaneous. That makes a lot of sense, though, because if your heart's pumping out blood like 5 liters a minute, and you're breathing 12 times a minute, right? Which means airflow is kind of changing every time you take a breath. You might get more air into these alveoli or less air into these alveoli. Then it's going to make sense. You're going to want to change where you're sending blood to, throughout your lungs. So it's actually kind of cool. So ventilation-perfusion coupling is how our lungs and our cardiovascular system work together to improve the efficiency of gas exchange. Because without this, you could be sending 10% of your blood flow to like a collapsed alveoli, which would make absolutely no sense. And then you're going to have bad gas exchange and then potentially respiratory failure from that. Cool. Okay. So the next question then too, you guys, is how is oxygen transported? Well, we already built the assumption that our blood can saturate, right? There's a maximal amount of oxygen that your blood can carry. And that saturatability is based on 2 major factors. First of all, how much blood is there, right? If there's a lot of blood, then you're going to be able to absorb more oxygen, right? If there's less blood, you're not going to be able to absorb as much oxygen. So 1.5% of the oxygen that's absorbed by your bloodstream dissolves straight into the water of your blood. And I'll give you guys an example of where you've ever seen this before. If you ever had a fish tank before, you got to put a little bubbler in the fish tank, and when the bubbles kind of go up to the water, some of the gas that's in those bubbles dissolves in the water of the fish tank, right? That's what the fish use to breathe because it moves across their gills, and they absorb that oxygen from the water. Same thing kind of happens in your body in the sense that some of the gas in your alveoli gets absorbed straight into the water of your blood, just like water in a fish tank has some gas in it, right? But it's not a lot. Only 1.5% is actually dissolved in plasma at any moment in time, okay? Now, 98.5% of that is actually bound to hemoglobin. Hemoglobin is a protein that helps to transport gases like oxygen and carbon dioxide, even transports carbon monoxide, but we'll talk about that later. Now, 98.5% of the oxygen that you can absorb gets bound to hemoglobin. The way hemoglobin works is you have a little central iron atom that oxygen can kind of associate with, and every hemoglobin molecule can carry 4 oxygen molecules. Okay? In fact, there's a relationship between saturation of hemoglobin and partial pressure of oxygen, and we call this the the oxygen hemoglobin dissociation curve. So if we check this out here, you guys, down here shows the partial pressure of oxygen, and up here shows the percent saturation of hemoglobin. And this curve shows the relationship between the two. So at 20 millimeters of mercury, your hemoglobin is 40% saturated, right? At 40 millimeters of mercury, your hemoglobin is 77% saturated, okay? At 80 millimeters of mercury, your hemoglobin is almost 100% saturated. And 100 millimeters of mercury, it's 100% saturated. Okay, but do you guys see the slope of this line? It's not a linear relationship. In fact, it's kind of more of an S curve. So that the steepest parts of the curve are in the middle here. So you get the biggest changes in saturation at the kind of medium partial pressures or even lower partial pressures, okay? And then once you get up towards, a higher partial pressure, you get smaller changes in saturation, which is denoted by this sort of less steep line, right? So this relationship is nonlinear. That's one important to think about. And this relationship can change. And it changes based on two major factors, temperature and pH, which we'll see on the next slide here, okay? Now, one thing that's important to note, you guys, on this, they're actually have little pictures to show you, which is kind of cool, is that as soon as oxygen binds the hemoglobin, it actually makes it easier for the second one to bind, and the third one to bind, and the fourth one to bind. So by even having any oxygen bound to hemoglobin, it's easier for another oxygen molecule to bind again, okay? That's why the slope of this line gets steep here, because once you get hemoglobin bound, the next one binds easier, which means you get big changes in saturation with smaller changes in partial pressure. Okay, kind of keep that in mind. But let's check out this next slide because this is going to be more kind of physiologically relevant to how this can change. But before I do that, you guys, what was kind of the range we talked about between oxygenated and deoxygenated blood? What was oxygenated blood around in terms of millimeters of mercury? Right around 100, right? So at 100 millimeters of mercury or so, what's your hemoglobin saturation? 100%. So your hemoglobin is 100% saturated, which means that it cannot carry any more oxygen. And that kind of makes sense because that was right around the plateau that we talked about. So that would help determine the plateau. So if if all of your hemoglobin was saturated, it can't carry any more than that. Okay. But then what was deoxygenated blood at? Do you guys remember? Right around 40. Right there you go. So physiologically, we're kind of operating in this range here, between 40 and 100. Okay. But this data show even lower than that. So in fact, your oxygen levels can get lower, like 20, near 20 or so. You're never going to get to zero. But it can get lower if you're extremely metabolically active, like during exercise and that kind of stuff. Your venous blood is going to be even more deoxygenated. Okay, so let's check this out, you guys. Now, what these slides show, up top, let's focus on this one first. This is the same curves, but under different temperatures. Let's imagine this, you guys. Let's say if you had 4 different blood samples, and you exposed all of those 4 different blood samples to different temperatures. What happens is that relationship changes, right? So you guys see at 10 degrees C, which is colder. By the way, that's not physiologically relevant. Like your body's never going to be 10 degrees C, and you're not going, or if it is, you're not going to live to tell the tale, right? So, but the point of showing these extremes is that it kind of illustrates the difference better. So if your blood is cold, what happens to the slope of this line? Well, it gets steeper, right? Do you guys see that? That at lower partial pressures, hemoglobin is even more oxygenated. In fact, you guys see that hemoglobin is 100% oxygenated right around 40 millimeters of mercury. So at 40 millimeters of mercury, or PO2 is 40, your hemoglobin would be 100% saturated if it was 10 degrees C. Okay, let's go to the next one. At a different temperature, slightly warmer, do you guys see how much hemoglobin is saturated at this point? At a slightly warmer temperature, it's 90% saturated at the same partial pressure. At physiological temperature, which is 38 degrees C, it's about 70% saturated at 40 millimeters of mercury. And if your blood gets warmer, like you're actually hyperthermic, like if you have fever or you're hot, then essentially it's even going to be more desaturated, right? So you see that hemoglobin's only around 55% saturated at the same partial pressure. So you might wonder, well, what's the difference between all of these? Well, if you compare all 4 of these conditions, you guys, 40 millimeters of mercury is the concentration, right? So we're saying that at the same concentration, hemoglobin has different saturatabilities. So you might wonder, well, where's the oxygen going if it's not on hemoglobin? Well, it's going to be in the blood, or it's going to be out in the tissue, right? So it's either on hemoglobin or not on hemoglobin. So let's think about this, you guys. If your hemoglobin is 100% saturated, that means that it can carry the most amount of oxygen it can hold, okay? What if that hemoglobin is only 90% saturated at the same concentration? Where's the difference in 10%? Where'd it go? If it's not on hemoglobin, where is it? Between 100% and 90% at the same concentration of oxygen. If it's not on hemoglobin and your hemoglobin is only 90% saturated now, where is it? It's in the tissues or in the blood. You got it. It's off of hemoglobin. It's loose. When would you want to release oxygen into a tissue? Right? Does it make sense? Like, when would you want to release that into a tissue? Would you want to release it in the tissue if the tissue is cold? Why is that? Why would you want to release oxygen into a cold tissue? Because what does cold kind of imply about that tissue? It's metabolically inactive, right? You might even say dead. Good. So it's metabolically inactive. That's the assumption, right? Because heat is a byproduct of metabolism. Good. Okay. I mean, if you're at 10, yes, you're dead. That's true. That's why I was laughing. It's like, yeah, that's true. I mean, technically you're right? 10 degrees C, you're pretty close to freezing. You're not going to live to tell that tale, for sure. Unless it's like just your arm or something, not like your whole body. Okay. So how about if the blood in your body, all of a sudden, what if it reaches a warmer tissue like hot muscles? What can we assume about those muscles if they're hot? They're more metabolically active. If they're more metabolically active, what do they need? Oxygen. Good. Let's compare that, you guys. Let's say at 40 millimeters of mercury, up here, okay? Let's say if all of a sudden the blood reached your muscles and the muscles are hot. Whoa, wait a second. All of a sudden your hemoglobin dissociation curve shifted. In fact, it shifted to the right. So what happened when it right shifted? Well, it actually desaturated. So you went from, at the same concentration of oxygen, you went from about 70% saturated all the way down to about 55%. So what happened to that 15% difference between this blood and the hot blood? So where's the oxygen in that hot blood if the hemoglobin is 15% less saturated? It's loose. It's in the tissues now. But how does that make sense? Your blood went over to tissue, the tissue's warm, and all of a sudden, what did the hemoglobin do? It changed and it dumped off 15% of its saturated hemoglobin, right? So when it dumped off that oxygen into the warm tissue, it desaturated to a lower level, but now the oxygen's more loose and it's more able to be used by your tissues, right? So, another. I know. These guys noticed it earlier because they were like right by the windows. And what the heck was I talking about? So I got distracted by the guy caulking the windows. That reminds me, winter's coming. I probably should do the same. Oh yeah, so we were saying that hemoglobin desaturates in warmer tissues. But that makes sense because if the tissues are warmer, they're more metabolically active. Good. Let's think about the other side of this, you guys, too. What about pH? Remember, carbon dioxide is a byproduct of metabolism. But what did I say earlier about when carbon dioxide dissolves in water, what does it form? It forms a carbonic acid. Now, you got to get that acid out of your body, right? But if there's a change in pH, that also alters this dissociation curve, which is what we can see here, right? So we see normal pH, which is right around 7.4. Let's look at 40, right? So at 40 millimeters of mercury, your hemoglobin, they're saying here, is about 79% saturated, right? What if your blood became slightly more acidic? First of all, what does that suggest about the tissue if the blood became slightly more acidic? Is tissue metabolically active or not metabolically active? It's definitely metabolically active, right? Because the acid is the byproduct of the metabolism, because CO2 from metabolism makes an acid. So if your blood's more acidic as it goes through a tissue, that suggests that that particular tissue where it's picking acid up from, it's probably more metabolically active. So if you're hemoglobin, what would you want to do then to metabolically active tissues, or for them rather? You want to go, here you go. You dump off your oxygen. So what's the evidence for that on this graph? Well, it's right here. Looks like at 40, okay? So this is normal blood pH, but what if all of a sudden that blood flowed through muscle that's now acidic, and then all of a sudden, as the hemoglobin flows through the acidic blood and your blood pH changes, hemoglobin can desaturate. Not fully, but a little less, right? And we're saying the difference is about 15 millimeters, about 15% difference in saturation, right? But why would it make sense, though, to desaturate and dump off 15% of your oxygen into an acidic tissue? Well, acidic tissues are probably more metabolically active. They're probably going to need more oxygen, right? let's think of the opposite of this, you guys. What if you have a tissue, let's say like your liver or something, and what if it wasn't acidic? What if it was actually the opposite, like slightly basic? Let's think about this, you guys. So 40, what if the tissue is slightly basic? Do you want to deliver oxygen to tissues that are slightly basic? Probably not, because if they're basic, they're probably not metabolically active, because the acidity is the byproduct of metabolism, not the base. So what we find, you guys, is that hemoglobin actually is more saturated at higher pHs. So if they're higher pH, more basic, hemoglobin's more saturated. Lower pH, more acidic, hemoglobin's less saturated. And if you're at less saturated, it just means that it actually dumped off its oxygen into the blood. Okay. Now this is important to consider, and you guys will learn about this, as you go on, through pathophysiology, even when you got to move on to professional school, whether it's like nursing, PA, or whatever you guys go into, right? So this will come back time and time again. In fact, there's other factors that can affect what hemoglobin's doing under these conditions, but these are the two major ones. We have temperature and pH. So, do you guys have any questions at all about this one?